Hi, I'm Jack Cush, Executive Editor of RheumNow.com. This is the 13th of January 2017, and this is the RheumNow Week in Review. A number of interesting items on this week's news. An ARTIS study, that's the Swedish Society, a Swedish database registry for rheumatoid arthritis patients, has put out a lot of good information and recently looked at the issue of work amongst patients treated with aggressive therapy. Specifically, it looked at a large cohort of RA patients and whether or not they initiated their TNF inhibitor therapy within the first 5 years of symptom onset. In the end, when they did a 3-year outcome on this large cohort, they showed that for those patients who initiated TNF inhibitor therapy within 3 years, within 5 years, they noted that the return to work statistics were much better. Exactly 34% of patients had returned to work, whereas those who started their TNF inhibitor after 5 years, only 14% of those patients returned to work. Data like this, important in real world, underscores the need for early aggressive interventions. Another effort from the ARTIS registry was seen when they combined their patients along with the Dan Bio, a Danish registry, and overall they had 8,700 patients with spondyloarthritis, either ankylosing spondylitis or psoriatic arthritis, who were treated with a TNF inhibitor. And specifically, it looked at the safety of TNF inhibitors in SPA and whether this was responsible for an increased rate of cancers. So what they did show was that, in fact, there was no overall increased risk of cancer in those treated with TNF inhibitors compared to those not on TNF inhibitors. And specifically, when they looked at the 6 most common kinds of cancer out there, there was no individual increased risk for any of those cancers. So again, more data to suggest that you should worry about the disease causing cancer or being associated with cancer rather than the drugs we're using causing or being associated with cancer. Speaking of cancer, a number of years ago, there was an update from the FDA, a new box warning for hepatosplenic T-cell lymphoma. As you know, there is a warning about the increased risk of lymphoma, especially non-Hodgkin's lymphoma in patients with rheumatoid arthritis, and then also seen in the same patients who get treated with TNF inhibitors. But unique to the TNF inhibitors, FDA put out a warning about hepatosplenic T-cell lymphomas. This is a particularly aggressive, but nonetheless rare kind of lymphoma that had been previously reported only in young people who had IBD and who were also treated with thiopurine drugs. But now it was being seen with adalimumab, infliximab, a number of the other TNF inhibitors. Well, a recent update looked at this, the frequency of hepatosplenic T-cell lymphoma, and found that it was not associated with, in a large cohort study, not associated with TNF inhibitor use, but was again seen in younger people receiving thiopurines. So if you see hepatosplenic T-cell lymphoma, think again either related to their IBD or their use of 6-MP or azathioprine. Biosimilars, big in the news last year, about to hit the market in the United States. CMS in the United States has issued payment and claims processing information to allow for the use of the biosimilar to infliximab. This will now be called Inflectra, and this will hit the market at about a 15% discount. Not very much, and I'm not sure it's enough to warrant us to run out and use that drug, but it'll be interesting to see how this plays out. An analysis of the pharmacokinetics of methotrexate we cited on the site showed no interaction between, a significant interaction between methotrexate, nonsteroidals, penicillin, or PPI drugs. Important to note. We also note that PPI drugs, we wrote about that last week on RheumNow and talked about chronic use of PPIs being associated with a number of different untoward outcomes, and you can find that on the website. Chronic PPI use, interestingly, is associated with a higher risk of C. diff infections, especially those who are receiving chronic PPIs. So a 2.5-fold increased risk of C. diff in those on chronic PPIs. The FDA is now reviewing a new application for the new gout drug, the new urate-lowering drug called lesinurad from Ironwood Pharmaceuticals. They've already approved that drug, but now what they're reviewing is the use of a combination drug, meaning combining allopurinol with lesinurad for difficult-to-treat gout patients. It'll be up to you to decide whether that's important or not. Meta-analysis of over 1,000 patients with knee OA who were treated with platelet-rich plasma, or PPR, a very common intervention, usually a cash-only drug. It's not usually reimbursed. Meta-analyses of this in orthopedic trials shows a limited value in a number of sports injuries and peritendinous injuries. Anyway, the use of it as intra-articular therapy in OA of the knee patients compared to hyaluronic acid or normal saline shows that it was in fact better with regard to WOMAC pain and function scores. Surprising data, but certainly suggests the possibility of a new non-steroidal intervention for those who have chronic knee OA. An interesting news item was seen in Reuters asking the question why only a very few patients in diabetes trials are African Americans. It's estimated in the U.S. that 13% of the population who has diabetes is African American, yet in the clinical trials they're sorely underrepresented, and that's something that we also see in some of our arthritis trials, that there's an underrepresentation of many different treatment groups. So that's something to consider going forward. A comparison study of total knee arthroplasty compared to unicompartmental or hemiarthroplasty, a much easier procedure with much better recovery time, showed that actually the hemiarthroplasty was in fact better in some measures than the total knee replacement, and there were certainly less outcomes, problematic outcomes, and less complications. But in knowing those who do these surgeries, I'd say that the choice of getting a hemiarthroplasty versus a knee arthroplasty is very much individualized, and you need the proper patient to benefit properly from a hemiarthroplasty. If you have malalignment and genu varum, genu valgum, or an abnormal gait, those will not work. Analysis of methotrexate pancytopenia in the elderly found 94 patients in a review article showed that there was 24% mortality. The risk factors were being elderly, not surprising, having coexistent sepsis and hypoalbuminemia or hypoalbuminemia by itself. Again, we don't see much methotrexate pancytopenia. In fact, you're going to see methotrexate neutropenia way before you see pancytopenia. And again, it is more common in those who are elderly and who have renal insufficiency, and their dose is not adjusted for that renal insufficiency. But looking at pancytopenic, those are the risk factors that was mentioned there. A nice analysis of comorbidities in giant cell arteritis, a popular topic given the new therapies that may steer us away from steroid use in the future. An analysis of 768 patients looked at the development of comorbidities and found that there was a almost threefold increased risk of osteoporosis, a 2.5-fold increased risk of venous thromboembolism, a 1.8 or an 80% increased risk in serious adverse events, about a 50% increased risk for CVA and thyroid, and almost a 30% increased risk of diabetes. Many of those, as you can recognize, are probably related to the use of steroids, which are often leading the way in therapy in early and new onset giant cell arteritis. An interesting article comes from JAMA this week about exercise weekend warriors, which is either 150 minutes a week or a 75 minutes of strenuous exercise once a week. Showed that those who are weekend warriors, who exercise even that lower amount, not daily, but that lower amount, that an analysis of 63,000 plus patients showed that there was a 30% decrease in all-cause mortality when you compare those weekend warrior adults to the inactive. IL-6 inhibitors are also in the news. We certainly have one IL-6 inhibitor on the market, tocilizumab. A lot in the news lately because of the new trials showing its efficacy in giant cell arteritis and possibly even in severe systemic sclerosis that involves the lung. But behind it are two more drugs that might be approved in 2017, 2018, sirukumab and sarilumab. And then behind that is another 4 or 5 drugs that are in development as well, including drugs like clazakizumab and others. This should change the landscape. You know, many new drugs all targeting rheumatoid arthritis and with new indications. It's going to create quite a buzz and pose quite a challenge, which is why the name of the article was called the IL-6 Wars. This facts, the new indications and new drugs, plus the fact that what we are learning about serial use of TNF inhibitors, we're not really going beyond 2 or 3 TNF inhibitors. We need other choices. That the best second choice, a lot of studies are now showing it may not be best to even choose a second TNF inhibitor or a third TNF inhibitor when you have other biologics targeting other mechanisms of action. And then there's clear data showing that if you're a primary non-responder to a TNF inhibitor, meaning it never worked in you, it doesn't make any sense to go to a second TNF inhibitor. It does make a great deal of sense to go to another MOA, another mechanism. And certainly we see the same kind of responses even in early RA when you use a IL-6 drug compared to all the other drugs. So, and then we have these head-to-head trials showing that the IL-6 inhibitors, specifically tocilizumab in the ADACTA trial, or sarilumab in the Monarch trial, showed that it was better than adalimumab. So again, whether it was adalimumab versus sarilumab or adalimumab versus tocilizumab, the TNF inhibitor worked better with an ACR20 response of around 70% versus the adalimumab response, and that's monotherapy adalimumab, of about 50%. Again, multiple measures show that IL-6 may be a better choice. So the article basically is intended to say, beware, the IL-6 wars may be upon us in the next year or two. And lastly, an informational article about the use of DMARD therapy outside of rheumatology, and specifically by cardiologists who are using either methotrexate or interleukin-1 inhibitors, canakinumab, or even Plaquenil as a means of secondary cardiovascular prevention. So specifically, we have 3 trials that are currently in progress and have been going on for a year, and will probably come to some results and fruition in the next few years. The CIRT trial, CIRT, is a trial of methotrexate in at-risk individuals, looking at whether it can prevent an increased number of cardiovascular outcomes. Next is the CANTOS trial, CANTOS, testing the same effect for the intervention of canakinumab versus placebo. And lastly, a newer, just launched trial called the OXI trial, OXI, will test the utility of hydroxychloroquine, which we know has certain beneficial effects, which could be anticoagulant effects, anti-diabetogenic effects, a number of things that could also be beneficial in those who have or may be at risk for cardiovascular outcomes. So that's it for this week at RheumNow.com. You can go to the website and find these citations and more information. We'll see you next week. Have a great week.